Bonjour.
Good morning. Thank you for being with us this morning. As you can see, we have an infectiology session. I'm Christian TREPO, and I'm going to co-chair the session with you. And our first speaker comes from Vienna. She's a treatment to talk about what's Austria. You have the floor.
Bonjour, good morning. First of all, it's such a pleasure to be not only just in Biarritz again, but seeing all the colleagues and friends in person. And my special thanks goes to.
C'est un grand plaisir d'être ici et de présenter ma présentation.
I'm a psychiatrist by training to give you some information about a study we did on psychiatric comorbidity and HCV infection in prisons in Austria. First, my disclosure, the work was partly supported by pharmaceutical companies, but they had no influence on the protocol or data collection, and etc. And this study, of course, was submitted by the IRB of the Medical University Vienna, and everybody who is doing research in jail knows how difficult it is, because based on the Helsinki criteria, there needs to be assured that standardized ethic procedures are implemented, that the prisoners are taking part voluntarily. And it also was a lot of structural work before with all the prison authorities, because in the daily routine, it was required to bring the prisoners to a certain area, to be, the researchers were to make sure that they were with them alone and had the privacy to do the interviews. So we are aware of that the people who are in prison, and I have to say it's about worldwide, that the societies or the institution are very good in locking up addicts. They are not as good as locking up people with white-collar crime. And we do know that in prison everywhere, a significant amount of drug addicts are imprisoned. If they are there, we should use the window of opportunity to assess their disorders and to treat them properly, because this is going to be in favor for the public health. In the example of hepatitis C, not only in small Austria but also in France, the countries ratified the, let's see, I can point here, the Opcut Protocol, which is the optional protocol on the prevention of torture. And actually, if we prevent that the prisoners are not proper treated, it refers to torture. So the society should assure that standardized treatment is being made available in prison. You might be aware of the special documents for the guidance in prison, the Nelson Mandela rules, and there are several human rights treaties who should assure countries to have proper treatment of people in jail. There are many publications, like from WHO, Prison and Health, how the society and the individual country should proceed. And of course, there is doubtless that opioid maintenance treatment is the standard of care for people suffering on this disorder. I'm going to be guiding you now through our structured project. It's called EPSCAP. We standardized assessed ADHD and HCV in prison. And we had two cohorts. One cohort was that we were in 6 adult prisons to look into inmates who were actually opioid maintained. And then we had another small group. We looked at adolescents and young adult inmates. I'm not aware how the situation is in France, but based on WHO recommendation, younger persons up until the age of 24 should have the possibility to be in a special court for young adolescents to have special educational programs provided. This cohort of the adolescents and young adults, they have not been opioid maintained in opposite to the first group. So what was our standardized procedure was that everybody had, the researchers applied structured interviews, like the addiction severity index, which is actually was added to the crime module, and a special assessment for ADHD. Then we had a standardized HCV assessment in all the interviewed persons. And of course, we had to look into the medical charts about to get information on their medication. This is about the sample I can refer to. In the final opioid maintained adult samples, we have been able to interview and assess HCV in a cohort of 133 patients. And the sample of the young adults and the minors or the adolescents was a total sample of 71. Just to give you some information, what I think what was interesting, because of course we had to make we had to assure that everybody speaks proper German in order to understand the assessment. And in the younger people, we had to exclude 48 inmates due to the lack of language barriers. So in the prisons, they are surrounded in the Viennese area. There's a high proportion of non-Austrian citizens and who are unable so far to speak the language. And this is one of the requirements, that if they are jailed, and we only had people who have been sentenced, that they are guaranteed to have special language courses. So the sample characteristic, and I'm referring to the adults now, in this 133 inmates, we had about 22% females. The mean age was 35.7 years. And to give you an information on the opioid maintenance substances, we had methadone, we had levomethadone, we have slow release oral morphine, which is quite common in Austria, and we had buprenorphine. And if you just look very quickly on the mean dosing, you see that with the exception of oral slow release morphine, which is ROM, they are basically highly underdosed in their daily opioid maintenance dose. About half of them had antidepressants and antipsychotics, and unfortunately, 85% were on benzodiazepines, and partly even with very high dosing. And to refer to this figure, in our assessment, only 3%, this might be interesting for you in the course of my presentation, only 3% had ADHD medication. I can tell you because the people, the doctors in jail had a major reservation adding stimulant medication to opioid maintenance therapy. Also, we are aware that there are a lot of publications referring to the positive effects in administering this. So, just a very quick overview. What was the psychiatric comorbidity at the time of the interview? You see the highly loaded groups of comorbidity. The dark columns are the opioid maintained patients, and the light colors are the younger adults until the age of 24. We see, of course, as expected, a high antisocial personality rating, then a very high suicide risk. And this might be interesting. This is the report of the European Addiction Severity Index and the mini screen, that a considerable amount of inmates still have been using drugs in prison. As we know, that's the case, and we should not be surprised if they are having a diagnosis of substance use disorder, they keep on using substances. And of course, also affective disorders scored pretty high. So I come now to the results on how prevalent was the attention deficit disorder in this opioid maintained group of people. This is the publication to it, and everybody who wants to have the slide, I'm happy to share them with you. So we had yesterday a very interesting workshop with Wim van den Brink and Maurice Desmatais, referring to the high prevalence of ADHD. We do know what's going on in the head of these patients. They keep, you know, it's that, what the hell is this? Oh, it's just my mind. And we do know and it has been published so often, and that the high overlap between substance use disorder and ADHD, and in general, the high comorbidity in patients suffering on ADHD, and the very late, actually very often the very late diagnosis, very often they before become substance use disorder patients. And it was very interesting to listen to Maurice yesterday about how important it is to prematurely induct them, not only diagnose, but treat them properly. So this is known that substance use disorder and the high prevalence of ADHD. We do know that ADHD have a threefold increased risk to develop substance use disorder. And ADHD, what is very, very important, if people, inmates, and there is the so-called white paper, which was introduced about 10 years ago in Brussels from people who work in the prison, not from doctors, that people, guards, who said, these people are sick because they have such an impulsivity. And very often it yields to increased administrative penalization due to the impulsivity of these patients. The study aim was to look into childhood and adult ADHD assessment, and our hypothesis was the onset and duration of substance use was associated with ADHD as the psychiatric comorbidities, the high risk of drug abuse, which actually refers again to the risk of injecting drugs and to the associated risk of getting HCV or even overdoses. And we looked at the prescription of ADHD medication. So these are the results. How was the scoring in the childhood ADHD and in the adult ADHD? You find in black the opioid maintained group. So about 50% were positive for childhood ADHD, about 17% still were positive for adult ADHD. In the adolescent group, 45%. And 10% in the adult ADHD scoring. And these are the figures in the general population. So you see a significant diagnosis on ADHD. And if I refer that only 3% had ADHD treatment, and these 2% were not treated with stimulants, they were treated with adrenergic drugs. So what was the association? We hypothesized that there is certain factors associated to childhood ADHD versus non-childhood ADHD scoring, and how to expect. There was an early onset. Excuse me, it went too fast. There was an early onset on alcohol and heroin application. There was an earlier onset on all the other drugs, like using cocaine, amphetamines, cannabis, and also, oh, this is jumping so fast, I'm sorry. And also that the use of multiple substances and injecting earlier in the cohort of opioid maintained patients with a childhood ADHD than with non-childhood ADHD. So what is the difference in the adult ADHD between in the psychiatric comorbidity? The dark columns show you the figures on the comorbidity who are positive scored for adult ADHD versus the white one for non-adult ADHD. And you see, this is the spectrum of affective disorders. A significant increase on psychiatric comorbidity in the ADHD inmates. So what about the HCV? The HCV assessment is very necessary. We do know that basically based on human rights, every inmate who comes to prison should have a diagnosis of infectious diseases. But we do know there's a significant lack, and very often, even if the prisons draw blood in the inmates, they only look if there are antibodies and do not follow up into further assessments. Why is it so important to look properly into HCV? It's not only the X-fold higher prevalence, but it's the continuous risk behavior in prison. Very often they have sharing of shaving equipment. Very often they share needles if they tattoo. As we have heard, they still, of course, use drugs in prison. And there is a very low percentage of prisons who provide needle exchange. This was the assessment. This was the standardized assessment we have been administering in all the inmates, looking in the antibodies, but continuously looking whether there is some active HCV RNA and a current infection, and then, of course, check whether there has been treatment administered or not. And these are the figures. The figures show that antibodies were present in 74%. However, and this is the major mistake if it's not a standardized study, in many prisons, these results are stressed in the charts. And you see that in 45%, the inmates still were HCV RNA positive. So they have the viral infection and they would need treatment. This gives you the information. I know there's a high variation between the countries. The Mediterranean countries have other subtypes than we have. We have the majority subtype 1 followed by subtype 3. And then we asked, because there is a lot of education going on in our cohorts and in the harm reduction centers, in the treatment centers, everybody is informing the patients. And to be honest, in my treatment center, they were very proud when DAA treatment started that all of a sudden they got a very expensive treatment. And as in contrary to the prediction, these patients were reliable in their DAA treatment. So we asked the inmates, do you know your status on HCV? And it's always very interesting that basically they were very nicely informed about their HCV status. But here we looked into the estimation, who thought who is negative and who was really negative. So 80% were right in their judgment. However, 20% thought that they are negative and had a positive result. And in this cohort who did not know with their status, about 50% were positive on RNA. So basically they are informed, but we are really well advised to take this, to really look into objective data. So what is the special case? If we treat our inmates in prison, it's beneficial for the general population. HCV testing should be taken seriously at entry, but of course, periodically afterwards. Vaccination should be offered against hepatitis A and B. And if HCV is identified, of course, adequate treatment needs to be administered, and nobody should worry about the price, because if they are in prison, as we do know, they take the opioid maintenance medication, they can go on very nicely with their medication on HCV. And this is the paper which was published 2019 on the HCV infection in the two imprisoned cohorts, the young offenders and the opioid maintenance prisoners. In the young group, only one person was HCV positive, and this was a person with a former history of drug abuse. So I thank you very much for your attention.
Thank you very much. We wait a few questions. Possibly it's better to discuss after each topic because the topics are very different. If I may start, what's the story of paying for the treatment? Which budget is going to support the treatment?
I think this is a very important question, as to my knowledge in France, it's the health ministry who is providing the service. However, in my country, which is unfortunate, it's the Ministry of Justice. So we faced a lot of problems in doing this investigation because everybody was employed by the Ministry of Justice and they felt, of course, controlled about their assessment. But after this investigation, we had a lot of discussion with the individual prisons because individual prisons have their own budget from the Ministry of Justice. So they were really worried because of the DAA treatment, which is increasing. They needed an increase in the budget. And unfortunately, we have an agreement now that these inmates who are sentenced more than 6 months should be eligible for getting the proper treatment, which is not from the human rights standpoint correct, but it's a start at least that we do it.
Thank you. Yeah, this is a limiting factor. Any other questions? Tarik?
Thank you for your lecture. If a prisoner, a patient, is in a prison for a very short period, how do you manage the follow-up when you go to the prison and go out to know if he's cured or not?
Yeah, to do research in prison is not only difficult from the ethics standpoint because it took very long for the IRB to agree it, but it's very difficult because you interfere with the life in jail, you know. So we managed actually. We had a lot of great researchers. So a significant amount of my research staff was dedicated to try to do this prison study in a period of 6 months, because I felt it's going to be difficult if it's extended too long, because then the atmosphere might be changing and we cannot succeed.
Thank you.
Oui, I have a question.
Okay. Oh.
National Council on AIDS and Hepatitis, we, at the request of the Ministry of Health, we conducted a study last year in prisons to see what was the situation for the hepatitis C positive patients. And what we showed is that only 50% of the detainees are actually tested for hepatitis C first, but in France, the good news, the bad news is low testing. The good news is that about 80% of the patients tested positive for hepatitis C get a follow-up and a treatment on the midterm. So I wonder, one of the big difficulties was to work with prisons, and the fact that it was very difficult to get figures on hepatitis C, on testing, on medical consultations, and so on. So it's a research setting, as you say, but do you have information on how it is outside of the research in the prisons?
You know, I think this is the really leg. So I think it's very, very important to do a structured study, because in a structured study, you're going to be following each inmate about their real status. If you rely on the figures, you know, because there's a fluctuating stuff and it's highly underrepresented. So if you, it's only possible if you apply a structured design, then you will get reliable figures. And as you see in this study, it's pretty high. And this was actually the first one doing this on a structured basis in opioid maintained patient. And despite the fact this is a panel on infectious disease, I really reinforce all of you to do the ADHD assessment, because the ADHD assessment is from an economic standpoint very, very important, because if you treat the inmates, they are not only safer in regard to their impulsivity and intravenous drug use, but they have a decreased rate on relapse to criminality and to drugs. And there are some more recent publication, they refer the beneficial effect of lisdexamfetamine in the administration for the ADHD. And interestingly, if you initiate treatment, the prison staff, it's a positive reinforcement for them, because all of a sudden they realize they are difficult, impulsive patients are much better to deal with.
Merci beaucoup. Merci pour votre présentation.
Thank you for your presentation, and now we'll move to the next presentation. about care of hepatitis delta in 2021. So Tarik ASSELAH is an hepatologist at APHP, so he's got 15 minutes. Thank you very much, Jean-Pierre Deloed. I'm so happy for being here at such a rich Congress with such diversity. So I'm going to tell you about hepatitis delta, and it's an honor to be moderated by Gilles and Christian. And thank you very much for the topo. So this is my conflict of interest. So I'm a speaker and investigator for Gilead and Eiger because I coordinate some therapeutic trials for them. But, well, I also have other conflicts of interest. I've been twice world champion together with Zidane and other football players. So these are the goals, the aims of this study. We want to know about the epidemiology of hepatitis D in France. We want to be able to detect hepatitis delta. We want to know the consequences of this kind of hepatitis, and we want to know how to treat hepatitis delta. So first of all, hepatitis delta was identified first in 1977 via immunofluorescence. So this was a hepatitis that needed virus B in order to contaminate a patient. So it was a defective virus. It is an opportunistic virus. It needs hepatitis B and a cell in order to use both in order to contaminate. And we can see that this is the original article. And the professor is here with us, so you can ask him questions. So this is a virus. This is hepatitis delta. It's a circular virus with a big CG base, and the cell will take it for DNA, and it's going to transcribe and replicate it, and it's going to use the envelope of hepatitis B to envelope this. And since we're using virus B plus a cell, it is very difficult to target enzymes that belong to hepatitis D. It's very difficult to block, therefore. The prevalence of delta in the world, here you have a world map with 240 million people having chronic hepatitis B, and 5% of them are infected with hepatitis delta. So 15 to 20 million co-infected with hepatitis delta. Of course, this is just an estimation because there's no access to this kind of screening everywhere. So we know it's between 10 and 60 million people who are infected with Hep D. And of course, there's a higher prevalence of delta in the Amazon, in Eastern Europe. But we're starting to get to know this kind of transmission. We know that it's sexual contamination, it's vertical contamination as well for children who are not vaccinated, sharing syringes. So these are the contamination ways. And so the situation in France is the following. There's Deltavir. It's a multicentric study. We have a cohort of 1,100 patients with an ADN delta serology, with a DNA of delta serology. So this allowed us to map the situation of hepatitis delta in France. We've got 52% of patients coming from sub-Saharan Africa, 20% from Eastern Europe, but also 20% of French people who were not vaccinated and they were suffering from Hep B, and then they were infected with D. The average age is 37 years. 69% of them are men, and these are the risk factors. So being born in an epidemic country, also, well, the parental link, sexual transmission. There's also another risk factor, which is alcohol consumption, cigarette smoking, but also viral co-infection with HCV, HIV, and so on. So, of course, we have to be complete when we do the screening. I mean, when you're looking for hepatitis D, you also have to look for B and C. This is some work which was made at the National Center in order to see all the strains. And here we've got all the genotypes up till genotype 8. And it's interesting to see all these molecules, to see whether these molecules have an effect in the different variants. So this is interesting. Virology allows us to follow population movements and population flows. So to summarize this Deltavir study, we've got this profile of patients. So we've got 86% of patients who are migrants, but we've got local population as well, and we've got a progression that is more frequent towards cirrhosis than in other cases. And according to a study in the US, most people suffering from hepatitis B did not have a screening for hepatitis D, and therefore we tend to forget to check for hepatitis D. So if we don't think about it, well, the trend towards cirrhosis is fast. So if you see an increase of transaminases, we have to think that there might be a hepatitis delta infection as well. So hepatitis must be acute. If you catch hepatitis delta, you may have fulminant hepatitis, you may heal from it, or you may become a chronic diseased person. And there are many different studies showing that the risk is higher compared to other chronic diseases like hepatitis C or hepatitis alone. So the path towards cirrhosis is even faster with hepatitis D. And now we are studying this internationally, so we're going to learn much, much more about the natural history of hepatitis D. And having the diagnosis and better understanding allows us to treat better. So we should stop the viral replication of D if this is associated to a greater severity. So the markers, the serum markers are FibroScan, and this shows us that there's a very poor correlation. And we get to the therapeutic innovation treatments. So we've seen hepatitis delta, 20 million people in the world. We always have to screen people who have already got hepatitis B, because hepatitis D is even more serious. So we've seen there are many molecules with hepatitis C that are available in recent years, and there's a lot of research in virology, in hepatology. There's a lot of enthusiasm, and chemists tend to tell us about these treatments for hepatitis C. Now, for Delta, what's important is to learn about the replication of the virus. That is, how the virus enters the hepatocyte and how it gets out, and to analyze all the stages in between, because all the stages could become a target for the molecular treatment. So it's going to enter via a receptor that is the same receptor than for hepatitis B, and then you can block the infection of new hepatocytes. And the infected hepatocytes, of course, must be eliminated then. We've got the antiviral direct treatment like interferon lambda. You've also got inhibitors of farnelization like lorafarni in phase 3. And it's interesting because this is a treatment for progeria, for children who are born and they age very quickly. And lonafarmi is a medication that stabilizes the basal membranes. And this is another indication for treating hepatitis D. And then we've got NAPs, which are under early development. So, well, there is a lot of investigation, a lot of research, and this allows us to care for hepatitis D diseased person. So it allows us to to improve the care. So we've seen pegylated interferon here, which belongs to European and American recommendations. And even though it's not always authorized in the market, it's very much used. And 20% of respondents were not detected, but we could see that after a couple of years of follow-up, they would relapse in their hepatitis. So this means that we have to follow them very closely in order to check for hepatitis D. So for Delta, we don't always talk about healing. We only talk about healing when there is a seroconversion. So who could we treat with Epcludex? Because there is an authorization of commercialization in the European market that is conditioned to certain situations. And it's for any chronic Delta disease with adult patients with a compensated cirrhosis. We don't have the authorization for uncompensated cirrhosis. And we're going to privilege patients who are under risk of a more severe cirrhosis. So how to make the initial check for the viral load? We have to evaluate the viral load, we have to evaluate the cirrhosis situation, and we have to screen for liver cancer as well, and via an endoscopy. So how to treat? Epcludex, 2 milligrams twice a day. And first of all, we help the patient, and the patient can do this alone and can inject alone this Epcludex. And this means that we're going to block the replication without a treatment associated to pegylated interferon in order to suppress HBsAg. So you know that Delta blocks the replication of B. If we block Delta, it is preferable to protect patients via an analog treatment. So how to watch for virology? Well, we have to watch for transaminases. We have to watch for the viral load, which should be undetectable for virus D. So at 24 weeks, for example, it is positive. If we have no viral load anymore, we have to make an ecography, abdominal ecography every 6 months. We're going to check for the bile receptors. So if there's no jaundice, for instance, this is also another indicator. And for treated patients, the tolerance was good. So bulevirtide, that's a monotherapy that is very well tolerated. And we need complementary studies to know about the exact duration and long-term results. Because, well, we have to check for no cancer, no events. This is an algorithm. Any patient with hepatitis B needs a screening for hepatitis D. And right now, the kits that are available are very good for specificity. And if the result is positive, we have to check for the viral load. And we have to beware of the reference lab, because certain PCRs that are done are not of good quality. And we must not consider that the patient is healed, because there may be fluctuations. So we have to check twice a year, for instance. We have to check for cirrhosis. We have to perform ecographies, and we have to undertake treatments, for instance, with pegylated interferon. And this is a recommendation with other authors to see what the needs are for future treatments for hepatitis delta. And so we wanted to propose a strategy for treatment. So first of all, we have to show that there's a reduction of cancer, reduction of transplants. So these are the long-term objectives. And finally, to stick to my timing, the strengths, well, for any age hepatitis B patient, we have to screen for hepatitis D. and if there's a message of active drug using, multiple sexual relationships. And hepatitis B is very often accompanied with cirrhosis or with cancer. And the historical treatment is interferon, pegylated interferon once a week, just like for hepatitis B or C. And there's a new treatment that is going to be commercialized, Epcludex. It's going to be authorized in the US as well. And for any patient with hepatitis D with viral replication, and except if there's a case of uncompensated cirrhosis, we'll get 2 milligrams once a day through subcutaneous injection. And vaccination for hepatitis B is the best prevention for hepatitis D. Thank you very much for your attention. Thank you very much. We've got some time for questions. So are there any questions? So thank you, Tarik, for this great presentation. So I remember there was the situation of hepatitis B in the south of Italy with lots of users contaminated. And we saw that there was an epidemic there. And well, you showed us that we really need to avoid these kind of situations and we really need to target users. So from the epidemiological point of view, we know that in certain areas there's a lot of hepatitis B and probably D. And I'm talking about an epidemic that is happening in the US. So how do we do then also in France? And in France, there is, I mean, in Guadeloupe, for instance, there's 3 times more hepatitis B. So how to deal with these situations? Thank you for these questions, because it really allows me to add up some comments. There is not a perfect correlation between the prevalence of B and D. I mean, in certain regions, you may have a bit more B and a bit less D. For instance, in Cameroon, so you have to check for regions. In China, we said that there was no delta, but it depends really where you're going. So we're still missing some data, and we need to screen more for hepatitis D. Now, very frankly, we need to diagnose, we need to screen. So in order to really check these drug users, how to do. Now, the treatment for antigen ABS is reimbursed. So regarding blood samples, for instance, well, you can get those blood samples, you can look for delta. And today, there is Stefan Urban in Heidelberg who's developing a treatment for delta, but it's still quite premature. This is a very important point, because there's, well, no rules for the epidemiology of delta. For instance, in the Amazonian jungle, there's a lot. And, well, there are certain areas who are 10 kilometers away one from the other, and one area may have lots of delta and the other won't. So we are really missing the thread of this epidemiology, because it really does not respond to a classical population flow. So, well, I think that Tarik's strategy is a good one. And since it is very severe, we must know that 50% of Delta people are going to suffer from cirrhosis in a few years, and they're going to develop cancer. So services our hospital services are full of people who are 40 years old and they've got cancer. So we need to work on it, and it has to become a rule. So we need to check for those people who are just dropping on certain patients. We need to check for Delta much more. We're going to issue some European recommendations for the prevention of Delta. But of course, if people cannot access treatment, we're really missing opportunities. And, well, we have to treat our patients. Thank you very much, Tarik.
militant de toujours, un fidèle d'ATHS.
I'm very happy to have Pascal MELIN. Pascal, you have the floor, and is working very closely to the patients. Thank you very much, Mr. President. Thank you very much to the organizers for inviting me this year again. I'm happy to see new faces without masks. And I see that despite this virus, it has been possible to meet again. And of course, I'm very happy that we can meet in presence again. Jean-Pierre is I'm very fortunate that he invited me, and he gave me a challenge this year, talking about an attempt to detect through peers. 2 years ago, I came to talk to you and I talked about fly fishing. And you know that the objective of France is to remove or to completely extinguish hepatitis C by 2025. We are lagging behind because of COVID. And so maybe 2025 to extinguish hepatitis C is not going to be feasible. Well, I'm still pretty hopeful. And I'm going to propose the solution that we have. So instead of fly fishing, so trying to spot each patient, is trying to find another solution. So a few background information: hepatitis C is many people that are diagnosed, 20%, only 20%, and 1.5% treated. We have 5 million new contaminations per year, and we are trying to tackle this pandemic. It's definitely a disease of poor people, and you're better off if you're rich in a rich country with hepatitis C. This is a slide that was presented by Stanislas Paul, which I think is very important. You see that things have changed with universal access, and we see that the pandemic changed. Now, how many hepatitis C patients do we have in France? We are not even able to say. We think we have under 100,000, around 60,000 is one of the estimates, which means that 1 person out of 1,000 has hepatitis C in France, which is very telling, which means that we should do 1,000 tests to find 1 patient. However, we knew that we have reservoirs, migrants, people with the HIV, and people in prisons. So you see here that in HIV patients, it took us 10 years. We knew that we had this co-infection between HIV and hepatitis C. We are trying to tackle those persons in prisons. This is that brown line. We are working on those, and the infection rate is slowly decreasing. So depending on the country of origin, we have different contamination rates, and this is the reservoir which I think will be the most difficult to tackle. When we ask the health ministry or we ask the interior ministry, we asking them, well, what is the threshold when you estimate that we're done with the pandemic? And I think the drug users may be the ones that may reignite the pandemic. So at all costs, we need to continue testing, and we need to continue that the pandemic is not flaring up from the people who use drugs. Now, treatments are here. We do have the right solution, the right pair, so to speak, with 3 pills for 8 weeks or 1 pill for 12 weeks. So this is something that we have. We also have the right 3 of a kind, so to speak. So being able to do DRODs, to do gen experts, to check the viral load, and FibroScan is the 3rd solution as well. You may also say that we have a main deck. Main deck would have to have those 3 tools, but also have an efficient treatment. Now, in less than 1 hour, we can have a DROD, a FibroScan, a gen expert, and then we provide the prescription to the patient before they leave. Now, how can we have a royal flush? Because we could do even better, right? So this is our proposal. This is the proposal that we have in Montpellier. So we're going to be able to do things outside the walls, as we call it. And this is already what I mentioned 2 years ago. So we're going to try and have teams going at the grassroots level, going outside. So this is a work here by Dominique Larrey. This is a bus in which we embark a nurse, a medical doctor, and social workers as well. And so we go outside hospitals. And so in remote area, we detect patients that did not access healthcare. We're going to find drug users. We're going to find people with alcohol use, and we're going to help them access the pathway outside of the wall. So they do not have to come to the hospital is going to them. They do that in Perpignan as well. They reach out as well. They also have this screening as well. Colleagues did that in Australia as well. And the common point of all those actions is to have an outpatient solution. However, it has a cost. It comes with a cost. And so people keep asking, so how expensive is that? Well, I know it's expensive, but we're talking here about eradication of the disease, and we have to put enough resources. Now, it works, but I think we must do even better in order to eradicate the disease by 2025. I do invite you to read the poster by Hélène Donadieu. This is poster 25, if I'm not mistaken, and this is a very interesting poster. This is a community-based intervention in order to improve detection in active drug users. So the strategy is an RDS strategy, and I'm going to pick up on that. She did not, she selected a population of hidden users. So those are those users that will be the reservoir tomorrow if we do not tackle this patient base. So far, we've treated the easiest patients, so to speak. Now, those are the most difficult patients that we need to reach out to. 554 inclusions in 11 weeks. So this intervention was very successful. So what is it? Well, they did respondent-driven sampling. So what we do is we pay people to encourage them to be treated. So this is something that we've done in addictology already. So what we do is we take 15 new patients. Those are what we call the seeds. We give them money to be detected, and then we give them free coupons that they give to friends so that they are detected as well. And those will receive 50 euros if they are detected. And those 50 are going to receive free coupons as well. And then you have a snowball effect. So if they do that in Belgium, this is the snowball effect, as they call, and it works very well. And so, as I said, it's presented in the poster by Hélène Donadieu. So, of course, it's very costly, but it does work. Now, of course, you have this financial incentivization. And now on the graph, you see that some gave out many coupons when others do not give out coupons. But it's a bet. You're betting on the peers so that you can access all the potential patients in a potential patient base. So you're really betting on the patients, and it's a community-based option. This is nothing new. This is something which was started in 1996 in other settings. Now the results were spectacular. They were able to access people with no access to healthcare because they were homeless, because they had no access to health insurance reimbursement. But what we get is 55% of them who are cured, which is great. There was one lost to follow-up, and maybe that one to follow-up would even increase the percentage of cured people. Now, I would like to talk about another attempt, which we're very proud of, and it's called the road trip. The road trip is based on volunteers who were cured and who want to share the good word or the good news. Some of them are previous drug users, and so those are activists, so to speak. So they are trained in DRODS, in FibroScan, and they tour Burgundy, because this is in Burgundy, the region of Burgundy. And so they go on the road, they hit the road, and literally they are talking about the different options. And that way we're reaching out to those populations and we propose treatment. So those are peers talking to peers, talking about what they could benefit from. So the road trip started 2 years ago. We have new road trips every year. The last road trip was finished on the 15th of October, but I'm going to show you the results that we got with the previous road trips. So what we do is, again, serology, point of care treatment, etc. So this is what we could do. 317 users or subjects were detected. They all had a DROD. We couldn't find any HIV amongst them, so we were able to conceptualize this was a proof of concept, so to speak. So of the 317, we had 285 negative VHC, 32 were positive. So 3 refused to be treated. They didn't want to be treated. They didn't want to know. We had 6 which had a negative ARN and RNA, I'm sorry. And then we have 1 positive RNA, but with a FibroScan inferior to F2. So those, in a matter of 2 years, had a prescription, had a proposal to be treated. This represents 8.2% of everybody, of all of us who were tested. So this is a population of those 8% with a viral load. Those are going to be treated and hopefully are going to join the care pathway. So today, as I said, in the general population, we have 1 out of 1,000, while when we go in the most complex territories and the more complex reservoirs, we're talking about 8%, so a lot higher percentage than in the general population. Now, when we do Gen Expert, so we have a follow-up, and in the follow-up with Gen Expert, we had 1 patient with a failure to treat, we had 2 recontaminations, and we had 16 patients cured. Now, this is my proposal to have the perfect tool. So we have the right tools, we have the tools, we have the treatments, but we need to use the peers. We need to have the peers to find the right reservoirs, to find those people that really need us. Now, of course, we need to have the right structure and we need to make progress in that respect. And we cannot stop here. We know that there are reservoirs in psychiatric patients, in jails, we need to talk about this, in migrants as well. How can peers help to tap into those reservoirs? I'm sure that we will have a better understanding tomorrow because there's a workshop dedicated to that. Now, I'm going to try and potentially launch a debate. What are the testimonials by the peers? Well, the peers say we want to remain healthy. Recontamination is low, between 1 and 2%. And those patients, they say, we want to remain healthy. And the situation is complex when those patients are stuck, so to speak, between being cured from a viral load point of view and from an anatomic point of view. Now, you know that those patients, when they know that they cure from hepatitis C, sometimes they tend taking up drinking again. And so their liver may be damaged because of drinking and not so much because of hepatitis. So we need to follow up very closely on those patients. We need to check fibrosis. And I think those will be the secondary objectives after 2025. So we need to go towards a new concept, a road trip by peers, which I think is a great tool for screening. And I think in the future, of course, we need to cure people and we need to keep them under close follow-up so that they remain healthy. FibroScan for secondary screening and also reduction of alcohol consumption. Now, obviously, peers is not necessarily an expert patient. It's someone meeting someone else and trying to encourage them to be treated. And also, we try to create strong links in between peers and healthcare professionals. It has to do with trust. It's a different type of trust, but it has to do with trust. And so it's really this relationship between GPs and nurses and social workers and also peers. And again, as I said, keyword here is trust. Now, 2025 means two ATHS later. So not in 2 years, but in 4 years. So will we win that game by 2025? Well, I don't know. Again, this is a bet. I'm hopeful. We, of course, from an epidemiological point of view, we need to have a threshold at which we estimate that the disease will be eradicated. And I think that we need to bet on peers to be successful. Thank you very much. Thank you. I think you have the right approach here, and I think it's a major challenge. So we are really hopeful for 2025 to have questions for the speaker. Hello. Thank you very much, Pascal, for this presentation, for this conference. I have a question, but I find it pretty depressing. I'm talking about depression. Oh, you stopped your treatment if you're depressed, right? No, I'm kidding, obviously. I'm depressed. I'm going to tell you why. I think the treatment of hepatitis C is really the health revolution of this century. Can we talk about any other disease where we had a revolution in the same line as we had one? But in 2021, we're still talking about, oh, we need to detect and we need to treat. I find it pretty depressing, right? But okay, let's assume that. So do we have a share of responsibility? Yourself as a hepatologist, do you think that you have a responsibility here? And I'm hopeful, however, depressed but hopeful. Maybe we should not confuse the follow-up of fibrosis and detecting. Should we treat hepatitis C? We need to remove comorbidities. This is what I wanted to say. We need to remove comorbidities, and it is up to us, hepatologists. And I think we do not manage to eradicate this virus. Today, if you detect RNA and you treat, well, again, you need to encourage GPs as well to detect. You need to assess whether there are comorbidities. And this is the case of all of our patients, right? Be they drug users or patients in the general population. Most often than not, they have diabetes, they have alcohol use, and they are overweight, so there are comorbidities. So if we look at all those comorbidities, I'm sure that we can find a way. Well, all patients must be treated. You know, we treat in first intention. I think that's what we do. But those are very bold decisions that we should make. Now, we have some time because we need to connect with Don de Jarlais in the United States, and unfortunately we have some issues. So I take this opportunity to give again a testimonial of Mary-Jane Craig.
You see Mary-Jane Craig here. She's the pioneer of methadone in the world. She's the only woman, a full member of Rockefeller University, and she left us. She was very active. She was full of punch. So Don de Jarlais, I visited her, and she was really a very dynamic woman. So I hope that Don de Jarlais, who is also who's an activist, and he has a nice presentation. I don't know whether we'll be able to show it to you. How about maybe we can take this opportunity to talk about something else? Yes, I would like to agree with what Laurent said. Yeah, screen and cure. So eliminate hepatitis. We have there are barriers for treatment. I agree with you that general practitioners treat obesity, alcohol, and some recommendations are complex. And Pascal will say something too. In the barriers, I was angry with my colleague hepatologists. When you say general practitioners can do it, then in a few years they say it's their fault. And this dichotomy is unacceptable. It's not the GP to finish the job of the hepatologist. We have to rewrite history and say that we did it together. The GPs screened and sent the patient to the specialist, and now they can treat themselves. But we have to rewrite this history so that the doctor doesn't have the feeling that we have given up, that he's left with a hepatitis C. But the psychiatrists have the same answer. They say we can treat, it's so simple, but I don't feel like doing it. You just have to prescribe, but you're not an expert. So you have the barrier of psychiatry, the barrier of have access to the treatment. Complex patients can be in a structure for a few months to be treated. I did it with complex patients. And in the post structure, they said, you did it twice, enough. You took all the budget. So it's not only a matter of finding money, but we have to write in the law that we're going to do something practical. We had 20,000 treatments per year. Today, it's less. And it's hard to find the last patients. And I think there are simple ways to find these patients. Beatrice? Can you give her a microphone? I'm happy to hear that. I'm happy to hear you. I would like to point to the inertia of the host structures. I'm retired now, but concerning the XAPA, we still have some new cases, but we really cleaned up all the active files. It's not the case for all the center. This is still a problem, and I agree with the mobilization from the CAREDS centers, those who work with self-support, etc. We have a bus, okay, doing what you do with your bus. We do that in Marseille, in remote places, but we added something that we call the sponsoring. Those who were treated. Fake news don't happen everywhere. People treated with interferon, they don't rush to be treated. And we benefited from training sessions we did with peers who had been cured. and they helped, they supported people to come to be treated. So there is many possibilities from our outreach mobility and to expertise, not from your degrees, but congratulations to the hepatologists like Bruyère in Marseille. They understand that, they know the active virus patients will not come to the hepatologists. We have to go find them. Thank you again. Yes, you're talking about Marc Bruyère. He said that he had been helped by a nurse to screen 2 patients in an underground parking lot, and they were viremic patients, and he did 100% positive tests. In general population, you need a lot of patients to have 100% positive. So you have to go to this complex population. We still have 2 years, and then we have to work hard.
Bien, bah écoutez, on va passer les diapos de DES JARLAIS et de l'équipe, des équipes qui sont associées à ce projet, qui est un projet financé par la NRS et le NIDA, qui se déroule au Vietnam depuis déjà plusieurs années, et qui associe une équipe de l'équipe de DES JARLAIS, donc à la New York University, et puis des partenaires vietnamiens, particulièrement des partenaires de santé communautaire, le CHU de Nîmes et puis le XAPA Pierre-Nicole, comme vous le voyez sur cette diapositive. Alors après, je ne sais pas comment on passe. Ah, tu les as, d'accord. Donc voilà, vous avez tous les gens qui sont listés là, tous ceux qui ont participé parmi les équipes françaises, les équipes vietnamiennes et les équipes américaines. Diapositive suivante. Bon, ben voilà, donc vous voyez, Don est au centre. Donc les principaux objectifs de cette étude, c'était dans la région de Haiphong, au nord du Vietnam, c'était de réduire l'incidence du VIH au sein d'une population qui, comme vous le savez probablement, est principalement composée de jeunes usagers de drogue, qui sont encore aujourd'hui la population dans laquelle se transmet principalement le VIH. Donc, dans cette étude, il s'agissait essentiellement au fil des ans, puisque c'est une étude qui est déjà relativement ancienne et qui se reproduit chaque année, de conduire d'étudier les facteurs de risque pour le HIV, la prévalence du HIV, la prévalence du HCV et la prise en charge des personnes dépistées dans le cadre de cette étude. Il s'agit. Alors, vous savez, j'improvise un peu parce que d'abord, je ne connais pas les diapos, mais je connais bien le contexte du Vietnam où on conduit, nous aussi, une étude avec l'équipe de Jean-Pierre et des collègues américains. Et je connais le contexte de Haiphong. Donc, excusez-moi si de temps en temps, je bafouille un peu sur les diapositives que je découvre en même temps que vous. Cette cohorte, la cohorte qui est suivie par l'équipe DRIVE est une cohorte de 400 personnes. Et pardon, ce sont les HIV négatifs, excusez-moi, et pour la partie HIV positive, ils sont suivis non seulement au départ pour le dépistage, mais ensuite pour la prise en charge intégrée, c'est-à-dire aussi bien la prise en charge des addictions que celle de l'infection à VIH. Diapositive suivante, vous n'hésitez pas à ajouter des choses. Hein.
Mes méthadones maintenant ce traitement.
Oui, voilà. Donc ils utilisent une technique, une méthode que vous connaissez bien, hein, qui est la méthode dite de boule de neige, Respondent Driven Sampling, et les super recruteurs, on en a parlé tout à l'heure à propos de l'hépatite C, avec un modèle un peu similaire en France, pour recruter des personnes additionnelles dans la cohorte. à travers un système de coupons. Il n'y a pas ici de rémunération, comme le montrait tout à l'heure dans l'étude française sur l'hépatite C pour les recruteurs, pour faire entrer de nouvelles personnes dans la cohorte, mais il y a un système d'incitation qui est principalement basé sur des services de soins pour les personnes qui participent à ce recrutement ou à cette cohorte. Et les organisations communautaires qui sont utilisées sont assez efficaces et assez développées, contrairement à ce qu'on pourrait croire dans un pays comme le Vietnam où tout est contrôlé par le parti, même aujourd'hui encore, même si c'est moins visible. Il y a un réseau relativement autonome, relativement indépendant d'organisations communautaires, et notamment SCDI, qui est l'organisation dont vous avez vu le logo au tout début, qui a des antennes un peu dans tout le pays, et particulièrement dans le nord, mais aussi un peu dans le sud, et qui a beaucoup travaillé sur le VIH au fil des ans, et travaille maintenant aussi sur l'hépatite C. Diapositive suivante. Bon, vous avez là la population d'études, en sachant qu'au Vietnam, il y a quand même une particularité notable, c'est que de temps en temps, au fil des élections municipales ou régionales ou nationales, les progressistes perdent les élections et les conservateurs les gagnent. Et quand les conservateurs sont au pouvoir, régionalement ou nationalement, il y a assez régulièrement des campagnes des rafles chez les usagers de drogue, qui sont alors détenus dans des rehabilitation centers, qui en fait sont des centres de détention où est pratiqué un sevrage brutal. Oui, et ils vont rester là pour une période maximum de 4 ans, mais il est rare qu'ils sortent avant 2 ans. Donc c'est toujours très compliqué, parce que quand on gère des projets, notamment des projets de recherche au Vietnam, il arrive régulièrement que brusquement le recrutement s'assèche, parce que à l'occasion d'une fête nationale ou d'un événement politique local, les gens sont raflés et il est quasiment impossible ou très difficile d'obtenir leur sortie. On y arrive de temps en temps, ça nous est arrivé à Saigon d'arriver à faire sortir ceux qui étaient recrutés dans notre programme de recherche. Je ne sais pas si les amis de Drive ont la même facilité avec les autorités militaires et de police de Haiphong. Mais enfin, ça complique singulièrement les choses, et vous voyez qu'il y a une circulation des individus entre la prison et la cité. Diapositive
les 3000 en rouge sont ceux qui sont en traitement méthadone.
Voilà. Diapositive suivante. Oui, alors les difficultés rencontrées, c'est précisément ce que j'ai anticipé sur la diapositive, ce que je viens de vous expliquer, c'est-à-dire les interférences de police avec la prise en charge des usagers de drogue. Le fait qu'il y a assez peu de ressources financières disponibles. Cela dit, la méthadone est payée par l'État, ainsi que les services de délivrance de méthadone qui couvrent à peu près le territoire national. Les difficultés d'avoir du personnel formé, la stigmatisation qui est toujours très forte, même si tout de même, au fil du temps et au fil des ans, nous avons vu, et je pense qu'à Saigon en tout cas, mais à Haiphong c'est probablement la même chose, que finit d'y avoir quand même une certaine tolérance vis-à-vis des usagers de drogue et des personnes séropositives. Ça a diminué par rapport à ce que c'était dans le passé. Et puis, ce qu'on évoquait tout à l'heure, les detention centers. Diapositive suivante. Alors, pour donc mesurer...
To measure the incidence in the study period, I don't have much information, but I imagine they use the usual system where the usual procedure. They looked for seroconversion in the study population. You see that they have a cohort of seronegatives with a 6 months follow-up recruited with the snowball and there is more than 1,000 people each time, and the seronegative are around 500. The results: 3 seroconversions in 1483 person-years at risk in the cohort study, 0 in the following surveys, and 0 in the most recent one. So the HIV incidence is very low, and it's spectacular. In this specific context of Vietnam, with all the difficulties we mentioned, provided we set up an integrated prevention and care system for the drug users, we obtain spectacular results, which mean that in this context, we can eradicate the epidemics within this population of drug users, which is the key population. And it's in this population that there is still VIH transmission. If we consider the general population in Vietnam, the drug users in Vietnam, they mention here, we can see that there is a cascade of care. That means access to screening, access to treatment, and an efficiency of the treatment in terms of negativation of the viral load, which reached the objective. The incidence is less than 1 per 1,000 persons. There are less than 5% of active drug users who transmit HIV. Needle sharing is below 5%, and methadone access is high, around 40%. Now there is a question, as always, whether it's in Vietnam or elsewhere, is to retain the drug users in care, in the screening system, in the treatment system, and the difficulties are related to the Vietnamese context, because in the Vietnamese context, it's not possible today. The health authorities do not allow the use of methadone outside of the special centers, which is a case for buprenorphine, which is available in a few centers, but which cannot be given outside of these care structures. So there is this limits the access to these products, especially for those who cannot go to the centers for geographical reasons. The other challenge is the modification, the change in the profile of the drugs used in Southeast Asia in general. Today, there is a wild use of methamphetamines and other synthetic products in the sub-region, so it makes treatment more complex, and the approach. And also, it's not specific to Vietnam, the problems of comorbidities, psychiatric comorbidities. In Vietnam, the treatment of psychiatric comorbidities, it's just at the beginning, and it's not developed. In the framework of this DRIVE study, Jean-Pierre Michel developed a program of identification of psychiatric comorbidities and treatment of these comorbidities. We know that psychiatric comorbidities, that is addiction plus psychiatric comorbidity. That's a factor of the worsening of the prognostic and a factor of vulnerability. In the study, they don't mention it, but they've seen some improvement in indicators of adherence to treatment, both for HIV and addictions. Of course, the purpose is to maintain support to have a sustainability of the end of an HIV epidemic among drug users. So for that, you need to maintain a supportive policy environment. You need to maintain the prevention and care programs, which is not a major problem now in Vietnam. And as we said, the fact that things are changing in terms of practices and consumption, that we need to adapt to those changes in drug use and in the user profiles. The next step is to transfer drive methods to new areas in Vietnam, not so much in the south, because there are already many things going on, and it's quite robust with other actors, especially us. But in the regions where HIV is the most active among drug users is in North Vietnam along the Chinese border and the Laotian border. It's far away, it's mountains, and it's very difficult. And there you have many new products which cross the borders in that area. And I think that this is what the team mentions when it says that projects of this nature should be developed in the north of Vietnam in more important populations than the population in Haiphong. We also, 2 years ago, Patrick Ebrard was in the team, Vincent Trias, our local coordinator for our studies in the south. So we went to Dien Bien Phu and in the north area of Vietnam at the Chinese border, and the situation of HIV and drug users is terrible because the incidence is very high and there is an extension. More than 60% of the drug users in the care centers, but there are mountains, so it's very difficult to come. Those who must access to methadone substitution treatment have problems because the Vietnamese, those in the mountains cannot travel for several hours. So HIV is it's prevalent among 60% of drug users. So there is sex contamination with sex practices. So overall, the incidence of HIV in these areas is practically is out of control. So DES JARLAIS refers to the emergency to implement all these possibilities to reduce the transmission of HIV. So they have a new project which is called CHEER. The objective is to replicate DRIVE, so to do surveys to estimate the size of the target populations and the incidence of HIV, incidence of comorbidities in syphilis, chlamydia, the HIV cascade of care, the MMT program coverage, and the risk behaviors for HIV. No, that's a preparation period. I imagine that COVID made things more complicated, and maybe they didn't start. And we can see on the Vietnamese, those Vietnamese names are towns in northern Vietnam. The difference is that here they do a study where they take into account not only the drug users, but also the MSM. In the previous study, it was only the drug users. Okay, so they already have results. So you can see that the treatment of HIV patients is overall very satisfactory because they have more than 70% up to 90% of viral load. In conclusion, in a country such as Vietnam, which is not as easy, very easy to work in, they can, at least in the study region, I don't like the word eradicate, but they can have to the absence of transmission and circulation of HIV within the drug user population. And now they are working to spread the method to other areas, especially in the north, so that their excellent results can be duplicated in other regions where the incidence is very high. That's the last slide. We're very sorry that Don Desjarlais couldn't present these results himself. I think we can congratulate Gilles, who did first a scientific karaoke, and it's quite remarkable. So he was in Don's shoes. So if this was recorded, I can show that to Don. Thank you. I think that this session is over, and we're going to meet again at 12:15.